In today's EGP Learning, we're going to be digging into health inequalities and what you need to know and could be doing about it. So let's go. So Gandhi, interesting topic to talk about today, health inequalities. I know I've been hearing a lot more about it recently. It's receiving a lot more attention, but it's an issue that's been around for a long time. We both work in areas of high deprivation, so I'm sure we've seen a lot of the effects of health inequity over the years. When did you? Is this a concept that's new to you, Gandhi, or when did you first come to think about inequality?
It's a term that's become more prevalent over the past few years, but I think it's something that's always been in the background. So, as you mentioned, we both work in fairly deprived areas of Nottingham. The deprivation aspect in particular is a driver for health inequality in our local practices. But I think it's also important to recognise that inequality is not necessarily deprivation. It's a huge portion of it, but it's not the only cause of it. And I think there's other elements that go into health inequalities. Patients with, for example, learning disabilities face constant health inequality. It is not just about deprivation, but deprivation for us, at the very least, is a huge portion of what we deal with. Multi-ethnicity working, non-English speaking is a huge part of that. Infrastructure plays a huge element in terms of health inequality. And important to remember that your medical health only determines around 20% of your overall health itself. That actually all these other aspects like infrastructure, where you live, your education, even something as how far you live from a bus route can have more of an impact in some ways in terms of your general health, in terms of other aspects. And that's what drives inequality.
Yeah, so I think it's something that we've all instinctively known for a long time. That people in deprived areas or groups who are marginalized or who struggle with access to various things that are required to live a healthy life experience worse health outcomes, but it's something that I think we've been provided with more frameworks and more information, and that I'm beginning to understand in a more real way. So let's dig in. So
and I think the other thing to remember, COVID has shone a massive light on health inequalities. That's one of the key things, because there's this absolute recognition that health inequalities drove worse outcomes with COVID in particular, and that certain populations need to be looked at in a different way. And I think that's one of the reasons why it's now such a focus, because it shone such a light on how badly, generally speaking, the health aspect has dealt with.
And how different the outcomes from COVID were for members of different types of communities.
Yes.
So I was privileged to have the opportunity with some other colleagues from Nottingham to speak to our ICB board, some of our ICB board members on the topic of health inequalities recently, and we produced some slides. So I've got a selection of the slides that will probably help us just talk to some of these issues really. So the first slide, and this is quite a popular slide. I've seen this around quite a lot, which just helps highlight the difference between equality or health equality and equity, because they're not quite the same thing. So if we look at the people on the left of this picture, they actually have equality. So they've all got access to the same amount of support. In this case, it's a box to try and help them see over a wall, but it might be, a certain level and specification of healthcare. For some people, that's enough, and they can achieve a good outcome. They can see the baseball game. For some people, they can just about do that. And for some people, it's not enough because of where they are starting from or their current position. They just got shorter legs, less ability to engage with seeing over a wall than the taller people. That box isn't enough for them. And equity, they say, is actually achieving the same outcome, not providing the same inputs or opportunities, but support people achieve the same outcome. And what that means is that some people need less support to achieve the same outcome, and some people need more support. And that's how we see that the boxes have been redistributed here. Lots of different versions of this picture, aren't there, Gandhi? I know you've seen a few others.
I like the orchard tree one slightly more, because it also incorporates one of the other aspects, which is justice, which is about tackling the system changes and stuff to make a shift in terms of how it looks and things. But absolutely right. I think the way I would liken this for most of our GP colleagues, GMS income is the same no matter where you work, basically, generally speaking. There's slight variations that occur, but effectively, if you work in one population versus another, you get exactly the same amount of funding to provide that care. And actually, we know the fact that that is not what works in terms of delivering care and stuff. So, I would say the GMS funding for general practice is the left of it. And actually, what we need to move towards is the right.
Yeah, and we'll look at some of that, because actually even that's not true, Gandhi.
Yeah.
Because actually in areas of deprivation in particular, actually GPs actually are able to pull down less of that funding for their patients anyway.
Yep.
So let's crack on. So inverse care law. This is something that I think we've all heard of before. I was surprised to hear that actually it was coined 41 years ago,
and we're still dealing with it.
And we're still dealing with it now. So the availability of good medical or social care tends to vary inversely with the need of the population served. So those who need the most tend to actually have access to or access the least.
Yeah.
And those who need the least actually tend to have really good access. And it's something that we know. We've known it for 40 years, but we haven't been able to address it yet. And actually the fuller stock take, very recent publication, we've done a video on the fuller stock take, looking at it in more detail. But one of the key things there, it says, despite knowing about this inverse care law for 40 years, we've actually not been able to address it, which I think is really tragic, to be quite honest, because this does mean that people live shorter lives.
Yep.
And they live longer with disability, in their lives, longer period of time afflicted with health conditions. But we'll see some of that in some of the stats, later. And also Bex Fisher, just a shout out to Bex, she's probably on Twitter. We'll probably at her as we distribute information about this video. But she says general practice in areas of high deprivation is underfunded and underdoctored relative to need, and we'll see that in some of the statistics later. She also says she had a really interesting comment to the Health Select committee a few months ago when she was talking to Jeremy Hunt and taking questions from him. And she said that in areas of deprivation and areas of high health inequality, patients don't get old, she said. So they just don't get to that stage that we often imagine old people reach as great grandmas and people like that, because they don't reach those ages, which is really, really sad.
Just for clarity, that's because they die before they get to them.
Yes. Yeah, that's what she's meaning there. So quite a powerful statement. So Gandhi, we were talking about the different factors that affect people's health outcomes. And you were saying, only 20% of a person's health outcome is affected by their ability to access good quality healthcare. The rest is affected by other things, like the sort of health behaviours that they exhibit. Do they smoke? Do they look after themselves? Do they exercise? Do they eat to excess or not eat enough calories? All sorts of things like that. Social and economic factors, such as the quality of employment in the area, quality of education, level of income, has an impact. The level of support they have from their community and family, support structures is really important. And then there's elements from the physical environment. How good is their housing? Is it hospitable? Is it stable? Do they have a house? And how good is their air and water quality? As well, which can actually be issues in some types of housing accommodation in some areas in our cities. When I first started to look at these sort of statistics, Gandhi, I looked at that and I thought, why are they asking general practice to take increased responsibility, particularly through some of the DESERs and frameworks and the emphasis on population health within them? Why are they asking us? We're very busy already. Why are they asking us to take responsibility for all of these things which feel like they're outside of our control and perhaps more the purview of central government or local government? I don't know. Did you have that feeling, Gandhi?
Absolutely. I guess my answer to the why is because they don't want to fund it from anywhere else, and the capitation model of general practice means that they can try and squidge it through without doing so. But that's the slightly cynical version of me thinking that. But I think it's also the fact that the general practice is one of the only true general contacts that almost every person has across the whole population. It's that divergent point for most people. If you look at any other aspect of life, the GP is the one aspect that everyone still has some sort of contact with, generally speaking, apart from an exceptionally small, minute population that seems to hate GPs. But I think it's because of contact. We've seen the loss of the family nucleus over time in terms of general populations. We've seen the loss of religious contacts being the focus of communities and that kind of stuff in some ways as well. So actually, what other opportunities are there? It's basically school and it's health are the two main contacts for everybody that almost every person in the whole country would have access to.
I guess too, but not everybody has school age children, at the end of the day. So I guess it is healthcare. I guess we're a good, and there's a GP practice in every community. everywhere. So I guess it's a good, it's a logical place to structure some of this work around. And I guess if funded, but people will say, well, actually, there's a lot of, they will talk about the primary care network, the neighbourhood level focus that gives to the needs of a particular population, and the aspiration that was around primary care networks, particularly at the beginning, to incorporate and pull in those organisations that are responsible for some of these other areas of health outcomes. So I guess primary care networks could be building, networks amongst these people. I know that's some work that we're doing in Bulwell and Top Valley around the health forum that we've created, bringing together people who touch patients' lives in all these areas that affect their health outcomes. So just worth acknowledging the complexity there. Yeah, that was that statement from Bex Fisher that we were talking about earlier. I found that really, really powerful, actually. And it made Jeremy Hunt sort of just pause and take a bit of breath as well. So I was just going to give a shout out to the Deep End organisation, actually. And if people are beginning to work on health inequality out there, that might be the reason why you're watching this video. You might have got a new primary care network health inequalities lead role. It's a role that is mandated within, so I'm doing that now, but it's a role that's mandated within the primary care network DES. Every primary care needs to have one, and they might be using some of their leadership and management funding to fund that role. So you might be starting out that journey or working within a place-based partnership on those sorts of issues. Anyway, Deep End. Put into Google, Deep End Glasgow. This is a movement that started in Glasgow on the premise that you can visualize this a bit like a swimming pool, and for some populations,
that's your next slide, isn't it?
It is. That's right. There we go. So for some populations, they're actually they're operating at the shallow end. Some populations, some GP practice operating at the shallow end. Actually, people have they're stood on firm foundations. They've got quite a lot of good family support, good housing, good employment prospects in their area. Good physical environment. They actually have a lot of those things that support that 80% of their health outcomes, and they're doing okay. And to look at it at the surface of the water, everyone's in the same position, but actually if you look under the water, some people are operating the deep end, some populations, some practices, where actually those fundamental building blocks aren't there, and actually there's a lot of deep water where people can experience adverse health outcomes. And this movement was about bringing together in areas, cities, geographies, those GP surgeries that are operating at the deep end, and they tend to define it as being in the top decile, top 10% of deprivation. Is what they're about, really. They're really around deprivation and health inequalities, bringing them together so they can work together and support each other. And as from the previous slide, there's lots of chapters in the UK, lots of chapters around the world, and we have one locally in Nottingham, and that's how we got the opportunity to talk to the ICB board. Candy, I was just going to hit you with some stats here.
Go for it.
Just prove some things. Okay, so these are some statistics from the Health Foundation. People living in areas of deprivation experience worse health. This graph might look a bit small, but if you were to zoom in or follow the source, you'll see that actually people living in the 10% most deprived areas start to 50% of them will be reporting living in poor health about a decade earlier than, it might even be more than that, than people living in the most affluent areas. So you can look at it in terms of age, or you can look at it in terms of the proportion of the population at any age reporting they're living good health. People experience worse health.
And we've seen that. So about a year or two ago, there was that national report that showed that in where me and Andy work and live, have that exact same thing. So in the Rushcliffe area of Nottingham, you are likely to live 11 years longer in good health compared to if you lived in the populations that we actually work in.
Yeah, so that's comparing where we work to where we live, essentially. It's quite stark. People living in areas of high deprivation experience higher mortality rates per 100,000 population. And look, this is where COVID has really had an impact. You can see how it's disproportionately affected people living in the most deprived areas. Practices in deprived areas receive less funding per patient. So the government actually ends up paying less per patient in deprived areas than it does in affluent areas, which just feels completely the wrong way around.
Absolutely.
To me. And if you look at this graph, it's showing areas of least deprivation receiving about £10 per patient per year. So is that like 7 or 8% less per patient than in deprived areas who are receiving less funding. Why is this, Candy?
I think there's a variety of reasons. I think there's this view of trying to give everybody the same amount, because I think that generally there has always been this concept that actually they want to treat everybody with the same equality and not equity. I think the other aspect is the fact that actually that those areas of deprivation end up having to use more resources to offer the same level of care because of the type of population they're looking after, and because the challenges of working in those kind of populations, such as non-English speaking, we know has a huge impact on the consultation rate. That it takes at least double the length of time to consult with somebody who doesn't speak English, and that's just the actual consultation. That's not the health navigation. That's not the health beliefs aspect. That's not all the other stuff that comes into play with it. So that has a huge impact in the health inequality, and therefore that's why more resources are needed to have the same outcome.
Yeah, absolutely. So I agree with all of those things, but I think we're largely talking there to costs of healthcare, that the cost for the practice is higher. But this really surprised me, because it's actually the funding received is less in deprived areas, and I think that speaks to
just because they don't have the headspace to actually look at it.
I think it just speaks to the ability to meet targets with populations that don't come to appointments all the time when asked, that they don't necessarily have the time because they're making up for the lack of funding in those other areas that you described to claim for things.
It's not just that, it's the achievement level as well. And one of the most stark ones recently has been the change in the way that vaccinations have been paid for practices, in the fact that actually areas of deprivation, because of the challenges they have of engaging their populations to want to have their vaccinations done, because they've got more mobility of patients, they've got more patients who don't speak English, so therefore may not want to have the vaccinations because of those challenges, and also communities of health population beliefs against vaccinations. You and I both, in particular in my population, there's been real hesitancy around vaccinations because of mistrust and various aspects of that. So because there's those added things, we get paid exactly the same amount as an area like Rushcliffe, where I live and work, where generally people are more engaged with their health and want to be healthy and therefore have the ability to do so, that therefore they have higher vaccination rates compared to my area, which is lower. So therefore we get less of it because less of the opportunity to do.
Well, basically you get, where we get to the nitty-gritty of it, you start to get paid some of the funding for doing this in terms of QOF and IIF when you reach a certain level of your population that's vaccinated, and it increases to a maximum threshold. And people will say that it's easier to actually get to that lower threshold in areas with less deprivation because they don't face these challenges. So they can actually get paid that funding, whereas in an area of low deprivation, actually you might struggle to actually get to the level where you're getting even paid that funding at all. There's a few ways that we're funded to provide vaccinations, so you'll still get the tariff for doing the vaccination, but the meeting the targets element you might not get. And I think that's what we see in a graph like this. And I think that the way that funding allocated just really needs to be looked at. I think we all instinctively know this, but communities in areas of high deprivation have fewer GPs. We're seeing a chart of the number of GPs per 100,000 weighted population, and areas of least deprivation have the highest number of GPs, and areas of the most deprivation have the lowest.
Again, going to use our local area. I think the last report showed that in Rushcliffe there was one GP to, how many was it?
1,200 patients.
1,200 patients. Compared to the inner city where I work, where you work, I think it's 1 to 2,100, if I remember rightly. So nearly double the amount of patients being covered by one GP, because the density of GPs is just so low, because there just isn't the resources to support that. That's why you have challenges getting them.
I think it's the resources, and I think it's the attractiveness of working in deprived areas as well, which I think cuts a number of ways. I talk to my GPs. I've always worked in deprived areas, but some of our salary GPs have worked in other areas as well, and they will say, and if you work in a more affluent area, you'll find this controversial, but they say actually the work is different, and most of the time the work is harder for many of the patients in a deprived area, and that many people will choose to work in a better doctored, that's already has enough staff, place than somewhere that's struggling to recruit and has potentially more difficult work. And of course, if you're pulling more funding down per patient, your ability to pay and attract staff and GPs to work for you is higher as well. So in a situation where there is a restriction on the workforce, you're going to have deep pockets to pay for them to come. So all sorts of reasons why we're seeing these health inequalities. This chart was just to illustrate, these are some graph. So people might not recognise the shape of Nottingham City or Nottinghamshire, but this was a piece of work done around health outcomes in primary care networks. And if an area's got a good outcome, then all of these boxes are green. If it's bad, all these boxes are red. And it just shows just the distribution of health outcomes and health inequity across the different primary care networks that exist in Nottinghamshire, and even within Nottingham City, which is quite a deprived part of Nottinghamshire. North Notts also actually has quite a lot of areas of deprivation, so I just wanted to acknowledge that. So this speaks to a point about funding, which I think is a difficult question for the system to have, and that is, currently we have equality. So actually each of these primary care networks receives the ability to draw down the same amount of funding for their patients, because we're not redistributing based on inequality or based on deprivation. Everybody gets the same ability to draw down the funding. And if we really want to turn some of these red areas green, then we need to have a conversation about shifting some funding from the areas that are doing very well to the areas that are doing poorly. And that's a really, really difficult question for the conversation for the system to have, because patients and organisations that operate in areas that are doing better are going to be reluctant, to receive less of the new funding coming down or less of the existing funding. Difficult conversation. How would you tackle that conversation if you were the chair of the ICB and you had a stated objective, as our ICB does, to begin to consider health inequalities when allocating resources at ICB level? How would you have that conversation?
I would like to think that they would have it by having an open discussion and recognising the challenges, because there is a challenge with it when you've got an envelope of funding and you can't really go outside of that, and therefore how does that work? I think there does need to be an element of readdressing it, and how they do that. You're right, it is exceptionally difficult, because there's always going to be winners and there's always going to be losers. So do you continue with the status quo and just keep having the winners being the winners and the losers being the losers because they don't know any different, so therefore they can't accept that that's the status quo? Or do you actually try and change things for the better for everybody rather than a particular population? And that's the difficult part.
It's tricky, isn't it?
And often it's in my personal view, unfortunately, they don't do it because it's in the too difficult pile.
Yeah. There's an increased push and imperative to have those conversations, and I think an appetite on behalf of the leaders to go there where they perhaps haven't before. Now we have new ICB structures. It'll be interesting to see how it pans out. I guess people often use this argument about prevention being cheaper than cure sometimes, and that if you can improve people's engagement with the diabetes care, you'll have less costly hospital admissions and amputations. So I think there's often an argument in that area, although it can still be difficult to make progress with those arguments, because it means reducing some people's funding now with the prospect of improving efficiencies for everybody overall later. It's still very difficult conversations to have. The next slide. So I did this presentation to the ICB alongside people from a different area of Nottingham, which is very different to mine. So their area has a high number of first generation immigrant families, essentially. So they have a lot of problems that arise from different ethnicities or associated with different ethnic groups and cultural groups, and a lot of language problems in their area. And it was really interesting to prepare the presentation along with them, because my area is quite different. It's very deprived. We have similarly poor outcomes in very similar areas, and similar disparities in life expectancy with Rushcliffe, where I live, that they experience, but the population is really different. So we have quite low levels of diversity, quite a lot of white English speaking people, but they're very deprived. And actually the patient stories that I was hearing from them were different from our patient stories. And it just made me think that actually there's a lot of diversity in inequality, and the sorts of interventions that would help their practices won't necessarily help my practices, and vice versa. So in some ways, actually, that neighbourhood level discussion is helpful, I think, or neighbourhood level attention is the right direction to go. This is interesting. So practices I think we all sort of know this because we see the CQC reports and we see the patient survey every year. Just did an episode on the patient survey, actually, which we can link to somewhere maybe, or just check it out. But practice in deprived areas underperform on many metrics. So this is just looking at the GP survey reported kind of opinion of the overall service, with least deprived areas doing much better than most deprived areas. We've not got the 2022 figures, which actually showed a reduction for everyone in terms of satisfaction with primary care, but there's quite a big difference. And this is just one
10%.
Yeah, and this is just one measure. But actually, if you're not comparing these metrics, taking into account deprivation or other challenges that practices feel, actually it can be really, really demoralizing for those practices.
Absolutely.
In areas that are struggling. And in the past, we've used words like struggling practices and all sorts of other ways that have actually, I think, made practices in this situation feel a bit bad about themselves, been demoralizing, and actually been quite counterproductive for recruitment and all sorts of other things. Because what sort of practice would you like to join? If you were looking at the stat, if you were a GP looking for a job and you were looking at the stats, you'd probably join a practice that appeared to be doing better in metrics, wouldn't you? Unless you really wanted to help tackle, unless you had the framing of health inequalities to look at this through, which might enable you to think, actually, I can make more of an impact there. But that's a framing issue, isn't it? So I think that's an important part of addressing this problem, is actually having a different way of looking at it and reframing it and thinking in terms of improvements and impacts. I thought that was an interesting stat. I think we're nearly at the end of these slides. I just cherry picked some from that presentation that I did, but I just wanted to revisit this picture just to highlight that not everything needs to be a box. We don't even have to think about the things that we're doing in the same way. Sometimes you don't need a box. You'd be better off with a step ladder. The rungs are a bit closer together than clambering up a few boxes, for example. And the point I was making here was, when you talk to our populations, because we've been doing a lot of talking to our population about their challenges as part of our primary care network work and about the sorts of solutions they would engage with, you often get unexpected results or answers. So, for example, we have a smoking cessation service in Nottingham City, and it's the same offer for everyone, regardless of where you are in the city. And our practice, actually, our patients were telling us, actually, we find it a little bit technical to deal with. Some of the things that they're talking to us about nitrogen, monoxide, carbon monoxide, and nitrous oxide levels, and things like that. And it doesn't really resonate with our population, and they feel that they would do better with something that is different and maybe just comes at it from a different angle. But that's a very good service that's been designed with sort of gold standard, national smoking cessation practices in mind. So actually, sometimes thinking a little bit different and listening to the populations, is something that's necessary. Or two final points. There might be a few more slides actually, Gany. But so a lot of people, when the primary care network DES came out, said, the primary care network DES addresses all sorts of problems, and people might say, doesn't the primary care network DES address inequalities? There's even a requirement in it to tackle neighbourhood health inequalities. And so you'd be in danger of thinking it does something about wider health inequalities. And in a way it does, because it provides some resources that patients can use that the practices and the system can use to improve specific challenges that people in different areas face. But the thing is, it provides the same level of resources to everyone everywhere. So in affluent areas, they will still be tackling problems that their patients face to get their health achievement even higher. So it doesn't do anything about redistribution. This tackling neighbourhood health inequalities is about tackling inequalities within a neighbourhood, within a small primary care network footprint. And actually, the thing about primary care networks is they're actually made because there's lots of similarities within the population. So they're going to be areas of deprivation clustered together. So actually, tackling inequalities within there doesn't really do anything for the bigger picture. It's good work, and progress can be made on challenges with populations, but it's not the answer that people might think it is. We need to do more, is my question. And then other people say, doesn't the Carhill formula account for health inequity? And Jeremy Hunt was talking as if he felt that this was the case in the Health Select Committee. I like some of the work he's doing now on the Health Select Committee, but he was talking as if he did. But actually, this has been shown not the case. In 2019, there was an article in the British Journal of General Practice, for example, that demonstrated that for every 10% increase in the index of multiple deprivation, IMD, for a practice, their payments only increased by 0.06%. Their challenges are going to be increasing by much more than that, given the level of deprivation. So we need to really think differently about.
It's important to note that Cahill only looks at 6 different criteria, which, if I remember rightly, non-English speaking, which is one of the key factors of diversity, isn't incorporated in there. Deprivation is barely incorporated in it. It's more about age of population, gender variance, and a couple of other things.
There's a comorbidity weighting, which does speak a little bit to the increased level of adverse health outcomes in these areas. But actually, in practice, we can see that when applied, it does not make sufficient difference. Just again, go up 10% in the index of multiple deprivation, and it only goes up 0.06% in terms of the funding, which does not feel right. We'll probably leave it there. In terms of the presentation,
important to note that many people probably say, well, if Cahill doesn't manage the whole health inequality, why is it not adjusted? Why is it not changed? It's been in the too difficult pile for about the past 15 years, if I remember rightly. Apologies, I've got the dates wrong. But for pretty much since it's been created, there was an absolute recognition it was not fit for purpose. But it's just in the too difficult pile for many people to even consider addressing. And maybe they actually need to just realise the fact that it just needs addressing, not stick it in the too difficult pile.
Yeah, I think the profession has difficulty itself resolving this issue because it's about generating some winners and some losers. And it may be actually that now we're almost potentially taking this above the profession's hands, taking it to ICB level. It may be now that there is the incentive and responsibility lying with an organisation that has the power to look at some of these issues. But it'll be very interesting to see how it pans out. Any other big challenges that the system faces in trying to sort this out, Gandhi?
I think ultimately the issue is it's about readdressing the balance. It's about levelling up, shall we say? Okay, and the will for the system to want to do that will vary across different footprints, and the capabilities will absolutely differ across different areas as well. But I think it's always going to be in the too difficult pile. This is the problem. So we just need to address the fact that this is a challenge that faces our populations across the whole country and more focally in your local area. And what would you want? That would be the thing I would ask everybody. If you are living in these areas of deprivation, if you live in these areas of health inequality, if you have these challenges, would you not want equitable healthcare access? Because that's what the NHS is meant to be. It is meant to be a healthcare service for all. And let's be honest, it isn't right now. So how do we address that?
To meet people's needs regardless of ability to pay, I think is one of the kind of fundamental principles, which we're probably not meeting. However, if you're a patient at practice that's on the other end of this equation, do you want less? I don't know. Some patients might say, actually, I'm happy to pay for an increased level of accessing private healthcare. I know some patients are increasingly feeling the need to do that, and part of the rationalisation of that is that I'm lifting capacity from the NHS to look after people who can't afford it.
But the challenge is that the NHS we know is under so significant strain that even that element of people moving towards private healthcare to supplement their care is not making noticeable difference because the capacity is just so limited as it is.
Well, it's the same. It's the same scanners. It's the same consultants at the end of the day.
Exactly.
There's just a workforce crunch. It's people paying to jump the queue. People might say. However, I guess just being hopeful. Some things that I think have worked well going forward is, so I've seen some good work from primary care networks bringing together the different organisations responsible for all of those things that contribute to people's health outcomes. So I think some of that work is beginning to happen in a way that it wasn't before. So I think that's positive. I've seen some good work. It's often quite difficult, requiring multiple different organisations to work together. And I'm thinking, for example, of the Trailblazer Fellowship Scheme in Nottingham City, for example, and the Primary Care Network Fellowship Scheme that basically seek to, particularly the Trailblazer Scheme, place, it's normally newish, GPs, early career GPs, in a job, in a practice in a deprived area, and they will provide some additional funding, which comes through Health Education East Midlands, so through a different body, a training body, to support them to develop an area that they want and support them to study for an additional qualification in something that speaks to their career needs and the needs of the area. And that, I think that's a really good example, but it's required some passionate people to kind of make that happen, and it's required thinking differently, and it's kind of multiple different
resources
and money, with and different agencies coordinating. You know, the primary care networks, the GP practices were not able to just do that on their own. That required more sophisticated coordination, but at least people are beginning to think about it, talk about it. I think there's a big training need as well. One of the things I when I first saw that primary care networks were going to have a role in trying to tackle health inequalities, although actually that role, as we've seen, perhaps not what it appears at face value, I thought we don't know. I thought we don't know how to do this. You know, we don't have public health education. You know, we're not public health England. You know, don't feel really equipped to know what will work, how to go about doing this work. I think we're learning, and there are some education offers out there, but you know, it's a difficult area, and I think we're only just beginning to become equipped. But it's an interesting area. It's great to see these new roles out there, and I'm very interested to see where we are in 40 years' time and see if we've then addressed some of these health inequalities.
We will see. As ever, if you do have any comments or questions, let us know. We would love to know your thoughts on this topic. It's an emotive topic, definitely, and I think for us and myself and Andy, it's one that's very close to our hearts because we live and work in it. So we're actually really keen to hear from those who don't have the same challenges as us, who don't work in the same areas. How much of this has spoken to you, and what are your thoughts on these particular aspects? And actually, if anybody wants to jump in and join us on discussing this, actually, we'd be more than happy to do that again. So definitely contact us, let us know, stick it in the comments or Twitter, whichever route you prefer. If you are listening on the podcast, definitely leave us a review, see if this has been a valuable and emotive topic for you as well. And as always, at EGP Learning, we're here to help enhance your primary care and learning. We'll catch you in the next episode.